Today on the Operators Podcast, we spoke to Dr. Isakson about what it's like to run an allergy clinic. This is a type of medicine I'm not too familiar with. I learned a lot on this interview. I hope you do as well. Hope you enjoy. What's kind of then Dr. Isakson's journey to becoming a doctor? When did you decide to become a doctor? What was your path to becoming a doctor?
So this is kind of a lengthy story. I'll do what I can to make it abridged,
Go
but
for it.
I had family in medicine. My grandparents, my father was a pediatrician. My grandmother was a nurse quite some time ago. That's not really why I was interested in medicine. Actually, truthfully, I was interested in becoming a biomedical engineer. And I liked the idea of medicine, but not necessarily practicing with patients. But as I went through my studies, I found that I really wanted to get involved in patient interactions. So I did my pre-med classes, and I was pretty gung-ho on the idea of going to med school until I got to my fourth year with my physiology degree, where I took a course called Artificial Internal Organs. And I was really quite fascinated with the process of how they made those innovations rather than the result itself. So I kind of thought, well, maybe I should not go directly into medicine. Maybe I should do some research first. But I did take my MCATs, and those scores were good for a few years. And I figured I would make a decision on that later on. And during my master's, I really did enjoy the research, but I decided that I did miss the idea of patient interactions. And I found out that you could do research as an MD. So I ended up applying to med school and going through the program there and my training in pediatrics and allergy and immunology. So that's an abridged version.
So after med school, kind of what was like the first kind of place you started practicing medicine at?
Well, actually, after med school, of course, there's residency and then there's fellowship. Yeah. So what I ended up doing, originally I wanted to do research part-time and I wanted to do clinical part-time. I was trying to do it a little bit differently than your typical academic medicine provider. So what I did after residency is I was a pediatric urgent care attending at the what was the Schneider Children's Hospital back then in New York. And I did part-time allergy immunology research at the Einstein College of Medicine. Then I transitioned down to Florida to do my fellowship. And I was still trying to figure out that kind of model, but ultimately I settled on the idea of a position that I saw at MacDill Air Force Base. So they needed somebody to start the clinic from the ground up there. And I decided that that's something I wanted to do. And I'm not somebody with any military background. I wasn't in the military, excuse me, and I didn't have any family members in it. But I wanted to try to make that project start from the ground up. So that was really my sort of first allergy immunology practice.
And what year is that? That's like,
oh yeah, that's around about 2012, something like that, plus or minus. And I stayed there for maybe just about 6 or so years, just a little under 6 years. And towards the end of my time there, I decided that I had some entrepreneurial ideas, but I didn't want to quite go out and learn something completely new before I even knew how to run a business. So I decided I would open up my own clinic. At the same time, I started taking some courses at the USF Muma College of Business, and I got a master's of science in entrepreneurship. And I was working working days at MacDill, and then I was going to school at night. And eventually I founded or started my own clinic during my entrepreneurship degree and have been continuing on since then.
because I noticed like on the LinkedIn, there's your self-employed kind of years, and then there's your physician owner years.
Yeah. Well, I would say that the reason for that is because when I was at the Air Force Base, I was classified as what's called an independent subcontractor. So I was in effect my own entity, but I was working within the larger organization throughout the typical chain of command. But at the end of the day, like I'm sort of quote unquote my own boss there, but not exactly. You know, when you're in a big situation like that, big institution. So, but yeah, that's sort of the nature of it. I'd done some locums work, and then I made my way onto my own clinic.
So what's it like practicing medicine on an Air Force base? I can't even imagine. It's so unique. It's such a unique story.
Yeah, it is definitely unique, especially again coming from my background as a civilian. I think first of all, I'm happy to say that from a quality standpoint, certainly in allergy immunology, it's top tier. There's some really great physicians in the armed forces in general, particularly in the Air Force. They've done quite well in some of what we call our Fit Bowl championships, It's a sort of like a trivia game that we used to play in fellowship. So they're really excellent and rigorous training, very regimented. I would say to some degree, in a good way, uncompromising on ethics and safety. From an operational perspective, it certainly has its challenges because they're not just physicians and workers there, but they're part of the military. And as you know, we live in tumultuous times. So that can have an impact on operations and staffing and folks who are deploying to different places. And it can make it a little bit challenging also in terms of getting new types of things like clinical trials up and running. So I did find it enjoyable. I really liked working with everybody there. I got to see everybody from every version of the services and coalition and every branch, et cetera. But I did feel that there were some things that I wanted to do that I couldn't do in that environment, just to the structure and the things that I wanted to take care of on my own.
Yeah. And I love like a good American business success story where you're like, I'm going to go found my own clinic. And I really love just every time I hear about a doctor starting their own practice instead of just joining a hospital and just doing.
Yeah, I enjoy. I thank you for that. I have to tell you, it's funny. Like when I see all these posts on the social media these days, it seems like almost like a badge of honor where people say they got into an elite school and I dropped out after my first week in school to go fund this thing that's going to become a unicorn. Yes. And I respect that. That's great. But I'm somebody who's done it differently. And that doesn't really work out in healthcare, at least for what I'm trying to do. So I've studied quite a bit and I'm trying to do things on an iterative basis.
Well, I certainly wouldn't want to see a doctor that didn't go to university. Like, yeah, I just figured it out by myself.
Yeah.
I'd be a little nervous. So tell me about founding North Star. Like what was kind of the founding journey? Like you found a nice location. Why did you decide on the name North Star? You're probably like south of the United States.
Oh yeah. Well, that's true. But I've always felt that medicine can be very complicated and it's not always distilled in the manner that it needs to be for their patients. So I really view myself as sort of like a database of information to be sort of what we say like a constant and dependable guide or dependable light for people. So when people get lost in the healthcare system, we want them to be able to look for us, in times of need and find reliable information that's evidence-based. And by the way, that applies to us as well, too, as physicians. I mean, we're patients in the system, too. I think we forget that sometimes. So that was sort of the basis for it. We wanted to be a patient's North Star, somebody that they could always look to. And I thought it was a lot better than calling it Loren Isakson, MD, or Incorporated or something like that.
Yeah. Isaacson's clinic. So what is the hardest part about running an allergy clinic? I don't think we've had anyone, by the way, in allergy on the show. So you'd be the first.
Sure. Well, I actually think it's not just common in allergy clinic. I think it's common to probably any business. And the hardest part is finding the right people to work with. And that can be both internally and externally. Certainly in allergy immunology, we have a heightened degree of detail that we need to pay attention to. So for example, each allergy shot vial that we give to a patient is 10 times the strength as the preceding one. So if you pull the wrong vial from a patient, you can cause all sorts of health problems immediately. So we really need an extreme attention to detail. So you have to have somebody who's personable, committed, dedicated, and detail-oriented. And I think those are perhaps common problems in other businesses. But all the technology, all the reimbursements, it has its frustrations, but it comes down to really people.
Mm-hmm. And like, what is a typical patient interaction with allergy medicine?
Well, the thing is that allergy is not just allergy, at least in the way that we practice it. So we're allergy and immunology, and a typical patient interaction can be quite broad depending on where you choose to focus on. So when somebody finishes their boards, they can tend to focus more on allergy or more on immunology, perhaps more on adults or more on children. And to become an allergist immunologist, you either have to get boarded or go through residency rather in pediatrics, internal medicine, or med peds before you do your fellowship. So all that's to say, to get back to your question, is that I did my residency in pediatrics and I happen to like immune deficiency as well, which is very vast. So a typical interaction for me could be perhaps a young child coming in and they have an ear infection, but maybe it's not just one ear infection, maybe it's multiple ear infections. And then I have to decide, is that coming from the cat that's in their house, or do they have a genetic mutation that doesn't allow their body to make antibodies to fight infections? So the scope there is quite wide. We have to handle basic primary care as well as advanced immunology. And one of the things that one of our mentors used to say is, just because you're a specialist doesn't mean you get out of the responsibility of being a general doctor or general pediatrician. So we cover the whole scope. We don't own any one body system or any one organ. There's immunology in everything. And my day can go from hives to somebody with severe combined immune deficiency, and then back around again all in the same afternoon or the same visit.
So if someone has an allergy, let's say like I'm allergic to cats, this might be a dumb question. Isn't the solution like get rid of the cats, or is there something else that can be done?
Yeah, it is. It's not a dumb question. And no, you don't have to go and get rid of your cat right away.
Okay.
There's a lot of things that can be done. I mean, of course, there's people who don't want to do immunotherapy and they can take medicines, and medicines are really designed to make you feel better, which is okay for some people. But if you have an issue that medicines can't handle the scope of the symptoms, or people are perhaps forgetful or just don't want to take medicines, then you would look at things like immunotherapy. And really the two that would be applicable at the moment in mainstream practice would probably be allergy shots or drops, where we are trying to essentially train your immune system over 3 to 5 years how to tolerate, and that's really the word, immune tolerance, tolerate that cat allergen so it doesn't cause so much mischief in your life. There are some newer protocols out there. Some folks are looking at intralymphatic immunotherapy, which we're contemplating for the future. It's a much faster way, but yeah, we can probably tune a lot of people's immune system up so that they can tolerate a house cat. I will also mention there is another product out there. I can't give it my full-throated recommendation, but there is a product made by, I think, Nestle. It's a cat food, and the cat eats it, and it binds up some of the cat allergen, so it secretes a little bit less, and it makes things a little bit better for the patients too. So there are some commercial things you can do outside of the clinic.
And like I don't really know that much about immunotherapy, but like what's the science behind these like medications?
Oh, well, I hesitate to use the word medication on some level,
Oh,
because a
okay.
lot of it is really just, let's say, extracts is the right word, that we're extracting the relevant pieces of protein of the allergen. So often we're giving you some form of cat dander or oak tree or dust mites that, it's in a preservative or some sort of a diluent, we would call it, maybe like glycerin type of thing. And the science behind it, there's some that is quite well known and some that is still being investigated. But in short, what we're trying to do is these allergens work off what we call IgE, like Edward antibodies. And we're trying to shift that pathway from more of an allergic pathway or Th2 pathway, perhaps an inflammatory pathway, Th1 to some extent. And we generate these things called IgG4 blocking antibodies that sort of prevent the allergens from getting where they need to, and also some cellular changes. That's probably a whole bunch of boring molecular bio mumbo jumbo, but
No,
basically,
it's interesting.
we're,
It's
we're,
like some
we're trying to
science fiction.
basically, yeah, we're trying to detune the immune system and put it from one pathway and sort of gently nudge it over to another pathway.
Awesome. I always like to ask physician owners about insurance. Like I've seen the insurance. I have the website open on my other tab. I'm looking at all the insurance you accept. Like what's your relationship with insurance? Do you like insurance? Do you hate insurance? Is America doomed?
Well, I'll skip the last question, but do I like insurance? I mean, sometimes I like insurance. I don't have a problem with it conceptually, but certainly I'm sure you hear most doctors kind of gripe about reimbursements.
Yeah.
It is very frustrating that we do a lot of work, and there's a lot of nuance to what we do, which doesn't necessarily get reflected in the reimbursement. I think that the time factor that certainly we put in at this clinic isn't necessarily valued as where it should be. But we've been trying to use technology to help bridge gaps where we don't really want to compromise on care for the sake of speed, rather. And we don't want to just push people through the clinic. But it is tough. I had a friend who said you can't be good, fast, and cheap all at the same time. We're certainly trying to break that model a little bit and use technology to fill some gaps. But yeah, taking insurance as your sole stream is doable, but it is certainly challenging.
Yeah, and I was looking at the website now, and I think that I can tell that you are really invested into tech. I saw like the patient portal is there. I can get scheduled right into Athena if I wanted to. All this stuff. What is the tech like at the clinic? Uh,
Yeah, I mean, so we try to incorporate technology thoughtfully as best we can in a meaningful way. I say, and I hesitate to use the word customer, but we do try to think of the patient or the customer journey, which has multiple steps from how do you find us to how do you schedule with us, and then once you're in here, how do you communicate with us in a patient HIPAA compliant manner, and then how do we get patient education material to you? How do we document, and then et cetera, and scheduling follow-up. So each one of those points represents a node for optimization, but we want to do it in a thoughtful way that decreases the friction points for people. And so we do have different systems. I wish we could condense our systems a little bit more, but we're trying to do things that minimize logins and accounts or use single sign-ons when possible. Certainly in the documentation aspect, I've invested in artificial intelligence scribe, which has dramatically improved my throughput and accuracy. We're working on
yeah.
some patient education things that I have already, but we're trying to move that towards the front of the process so that patients can come in with an understanding of their condition so that we can spend more time on them rather than sort of explaining things immunologically. We can really get down to why are you here and what can we do for you. So we're constantly testing and iterating and trying to compress where we can, but not sacrifice on patient care. So did that answer your question, or do you want me to elaborate?
No, no, 100%. I mean, at Caesar, it's kind of the same idea. Like we're building all these AI tools. We have like an AI scribe. We have like an AI that can exist on your website that patients can do like refills, get scheduled in if they want. We have
Mhm.
a voice agent you can call, get scheduled in through
Nice.
voice. So it's very similar to kind of our idea. Um,
Mhm.
the overlapping thesis of what I think Caesar Health as a project will be is, can we get into direct primary care that's all cash pay and make it so that a clinic is so efficient and has so little staff that it's just like a bunch of AI agents running, and then you just have a doctor and maybe like
Mhm.
a nurse. Uh,
Yeah, I mean, you would probably still want some other people besides just a doctor and nurse, and I certainly think of these AI tools as tools to augment our experience rather than replace it. At the end of the day, you still want to have a meaningful discussion with the person to person, or even like we're doing now through the internet. But there's certainly room to cut back on redundancies and make the most out of the staff that you have for sure. But we tell people, notwithstanding all this technology, if just pick up the telephone and call us if you want, or stop by. We'll talk to you in person. We're still here. We're not putting barriers in between us through technology. We're just trying to make it
yeah.
more efficient and offer as many channels as possible to meet people where they're at.
And I always say that as well when clinics are interested in voice agents, like it needs to be able to transfer to
Yeah.
a staff member. Otherwise, it's like blocking the patients from direct communication. I noticed that you're also teaching as well.
Yep.
Uh, what are you teaching exactly?
Yeah, so I have a sort of faculty agreement arrangement with the St. Joseph's Internal Medicine Residency. They're over in Tampa. And a lot of folks who are going through residency, they don't really have a lot of exposure to allergy and immunology, or maybe they remembered that one lecture from med school that put them to sleep with the in-depth molecular biology. So my offering, if you will, is that we allow the residents to come in and rotate with us for a month. And we try to teach them about the immunology side specifically, and also the allergy side. And then because they're internal medicine residents, they get exposure to pediatric patients that they wouldn't normally get in our
Mm,
clinic. And then we also talk to them a lot about the business side of medicine, since I'm a solo independent private practitioner. And they don't really cover that kind of stuff in ACGME type of residency programs, at least not to the depth that I would like to see them doing it. So we're trying to give them a unique experience here. And I basically get in touch with the folks when they tell me they have somebody they want to come, and they sit with us for a month, and we try to give them some insight to it. And either they love it, or perhaps we talk them out of becoming an allergist in a month. I don't know. We'll see.
What does then your work life balance look like?
Yeah, I think it's interesting to use the term balance. I've been reading a lot about these posts on LinkedIn and balance. I find that everything kind of comes in spurts. Certainly on the business time side, it can come very quickly in terms of different things that I need to implement, and a lot of people wanting my attention. And the same thing happens with my kids and my family in terms of obligations and extracurriculars. But one thing I do not compromise on is my family. And maybe that's put me a little bit behind on some ways in terms of my total trajectory. But I know that if my daughter needs me for a school function, I can just go and close the calendar off since I'm the one who owns a clinic, and
Yeah.
they're going to remember me being there. We're going to have those memories together. We're going to go on trips together and vacation together. And, it may mean that that day or that month's a little bit lighter, but that's important to me. So my balance is heavily swayed towards family, personal growth, and I feel that our financial success is really a byproduct of that. I'm sure I could see more patients in the day, but we're doing okay with that.
And you mentioned kind of pediatrics versus, I don't know what the word would be, like
Well, just adults, yeah,
non-pediatrics,
yeah.
adults, whatever, non-children. What's the difference between pediatrics and when you're seeing adults?
Yeah, well, so that difference is quite noticeable when it comes to immune deficiencies. I would say really the majority of the severe immune deficiencies tend to present in little kids, although there are some
Yeah.
big ones you have to be aware of for adults. But you really have to change your thinking a little bit, especially when you see a little child who has eczema and a couple colds. You could say, like, are these separate things, or is this the beginning of something, again, like severe combined immune deficiency? Whereas if you saw that in an adult, you're generally past the time where that's a big issue in that regard. You still have to keep an open mind, but I think my awareness for severe immune deficiency is heightened in children for sure. Um, you have to make sure you bring some good toys to the visit to distract them. I suppose that
Mm.
applies to some adults as well, and they're
Yeah.
perhaps more enjoyable kind of visits. But yeah, I mean, on balance, a lot of them, both kids and adults, have the same kind of problems, and they're just sort of presented a little bit differently.
Yeah. I remember when I went to like school, elementary school in Canada, by the way. I know you went to
Oh, okay.
studied
Yeah,
in Canada for a bit.
I did.
I know. I do my research. There were these kids that just had super severe allergies. Like they had to have EpiPens, and if they ate stung by a bee was the big one, and the nuts. I always felt like there was a kid that if he ate like any kind of cashews, he would basically die.
Mhm.
What is up with that? I feel like it kind of goes away when you're I don't know any adults who carry EpiPens on them, but I knew a lot of
Well,
kids back in school.
I think if the adults are carrying the EpiPens, maybe they're a little bit more clandestine about it, and
Yeah.
certainly they're probably not in a work environment where the cafe has cordoned off a peanut-free zone in big corporate America or Canada, I would imagine. But yeah, I mean, some of these things are very, very severe. The one thing, you're right, some people do quote unquote outgrow them or lose some of their sensitivity over time. And we've gotten some molecular insights too. For example, if we broke down the peanut protein with component testing, we could give some people an insight as to whether it's more likely to be a severe reaction or not, give them some guidance on their prognosis. But um, there's some newer treatments that are available that we didn't have access to. First of all, of course, there's classic avoidance and epinephrine, but now we have a monoclonal antibody as an auto injector called omalizumab, which you could give to somebody to really drastically raise that threshold. So, somebody might be taking that at home and you have no idea. So you might not see it quite as severely. There's oral immunotherapy where they try to induce tolerance, much like shots, but you're giving it through like a powder in the mouth or something to that effect. There's a new product called epicutaneous immunotherapy, EPIT, which is in clinical trials. It's essentially a patch or a platform that you would, I'll use the term spray, but that's not necessarily accurate. Apply the protein of interest to that, and your skin generally induces the immunity, or you learn the immunity through your skin. And then some people do sublingual immunotherapy drops. So the point is there's a lot of things that are either currently on market or coming to market to treat some of these really severe things that we didn't have before. And maybe you wouldn't have seen people carrying the EpiPen. And then also there's a new delivery device. There's a nasal epinephrine, which is very small and clandestine. And it's I think I have my demo device here. I'll try to cover up the brand name, but it's like that, and that's the slot. At any rate, it
You
goes
put it
up
in
your
your
nose.
nose?
Yeah, it goes up your nose. It works fairly similar to the needle, but it's needle free. And it comes in a tiny little carrying case that you can sort of seclude away or hide away. So some folks may have it, you just don't know. They're being sort of discreet about it.
Yeah, that's a fair point. Well, Dr. Isakson, I don't like to run these too long. I like to keep them around 30 minutes. Is there anything you think that is worth mentioning that we didn't chat about on the show?
I mean, I think that people should recognize a few things. As it says in my name, North Star Allergy, Asthma, and Immunology, allergists are also asthma specialists. So that's a question I get a lot, or a sound of surprise. So if you're somebody who struggles with severe asthma, I would make sure that you speak with an allergist. It's not just pulmonologists who handle that. And same thing with eczema. There's a lot of dermatologic conditions that overlap. But I would refer people to the Jeffrey Modell Foundation. If you're having a lot of odd kind of infections or repetitive infections, I think it's modell.org or something to that effect. And you can find the 10 warning signs for an adult and for a child of when you might need to consider an immune deficiency. It's a big part of what we do.
And with asthma, like what do you do for your asthma patients? I knew a couple of kids who had asthma as well growing up.
Yeah, sure. I mean, there's a lot of different types of asthma too. So first you got to figure out which one you're talking about. So certainly allergic asthma is a big part of what we do, but you could have infectious asthma, you could have occupational asthma, you could have eosinophilic asthma. But if we use sort of like allergic asthma as a base case, you would want to make an assessment of really what's their severity and how persistent is it? Is it mild, moderate, um, you know, severe, persistent asthma, et cetera? You would want to have an understanding of the comorbidities that might be contributing to that. Is it, weight or other breathing issues? And then you would probably need to do pulmonary function testing or spirometry to take a good look at how their lungs are working and use our evidence-based guidelines to figure out, does somebody need to be on some sort of controller medicine? Maybe like an inhaled corticosteroid. But the goal is not to keep people on all these medicines all the time. So if they do have allergic asthma, and those folks, at least, there probably be a good recommendation, if eligible, to go on immunotherapy of some type. Typically, shots would be better, although if they're severe, you might consider biologics. Of course, I always make my disclaimer: I'm not your doctor, so you should talk to your doctor. I don't know enough about you until you become my patient. So these are sort of educational things as opposed to
Yes.
blanket recommendations.
It'll be on the screen flashing. Last question then before we call it. How much time is going to admin versus seeing patients at the clinic?
Yeah, I mean, I'm not sure if I could put that in time other than to say too much.
Yeah.
I would say that
Pajama time. You ever heard of the pajama time?
yeah, if I have time to get into my pajamas, but I would say that I would say that the promise of the electronic healthcare record has been that it will increase efficiency and decrease the amount of paper. I found it has been the exact opposite of that. But I will say, as of 2026, I'm finally starting to feel optimistic because some of the companies are making AI native encounters, not just with the ambient scribes, but all sorts of things. It sounds like what you guys might be doing too. But I'm going to be able to drastically rework the amount of documentation that I need to do because I'll just be able to find information so much quicker than I could. My big issue was making sure that my review of systems was up to date across all body systems. And when you're dealing with an immune deficient patient, that's a lot. It's essentially a chart summary at every visit. But I'm feeling gradually now with AI and data mining, I'm able to back off a little bit on the total scope. So I'm optimistic of being able to get into my pajamas at some point.
Yeah. Well, thank you so much for coming on. I appreciate it.
Yeah, you're welcome. Thank you so much for having me.